All right, so today we're taking a deep dive into central serous chorioretinopathy. And to guide us on this deep dive, we've got this brand new evidence-based treatment guideline from Progress in Retinal and Eye Research, the one that just came out in 2024.
Yeah, it's a good one. It really pulls together everything we know about CSC so far. It's like having the ultimate cheat sheet for diagnosing this condition and understanding what causes it and then figuring out how to manage it for our patients.
So jumping right in, I mean, we all see CSC in our practices, but I'm always amazed by just how many different ways this condition can actually present. What would you say are some of the biggest challenges you face when you're trying to nail down a diagnosis?
It's like trying to find a contact lens on a shag carpet sometimes, right? It's there, but pinning it down can be tricky. I think the biggest pitfall is assuming that every time we see fluid under the retina, it's automatically CSC.
Yeah, and that's where all those mimickers come into play. Table 1 in this guideline is like a gold mine for anybody who wants to, really sharpen their differential diagnosis skills. I mean, did you realize that there are over 13 categories of conditions that can mimic CSE?
Yeah, it's enough to make you want to reach for the ibuprofen. But seriously, that table is a lifesaver. I mean, it reminds us to think outside the box and, consider things like neovascular diseases, inflammatory conditions, even tumors in some cases. You really can't rely on just one single clinical finding.
Absolutely. Multimodal imaging is key. OCT, FA, ICGA, FAF. We need the whole arsenal to really paint a complete picture. And even then, we have to be super meticulous. I was particularly struck by the point about wide field FAF even, that can sometimes miss those subtle gravitational tracks.
It's like trying to spot a chameleon in the rainforest. You really have to know what to look for and have the right tools for the job.
Yeah.
And speaking of tools, how about we talk about how we classify CSC once we've actually made the diagnosis? It's not as straightforward as acute versus chronic anymore, is it?
Not really. And the Central Serous Chorioretinopathy International Group has come up with this new classification system that goes beyond just how long the condition's been going on. They talk about simple versus complex CSC, which I think is a really helpful way to think about things.
Yeah. I think it's a much more nuanced approach, and it gives us a better grasp on the potential for vision problems down the road. But it also brings up a really interesting question. How do these classifications actually change how we decide to treat the condition, and ultimately, how does it affect our patients' outcomes?
That's the million-dollar question, isn't it? And I think it's something we're all going to be grappling with as we get more and more familiar with this new classification system. But before we get lost in the treatment maze, let's talk about risk factors. I mean, we know the usual suspects, male, middle-aged, but I think corticosteroids are the real wild card here.
Corticosteroids, yeah, they're like the Jekyll and Hyde of ophthalmology. It's amazing how even a tiny bit of exposure can trigger CSC in certain patients. It makes you wonder what makes some people so susceptible.
It really does. And then there's that whole type A personality connection. Is it real or is it a myth? What do you think?
I think there's something to it, even if we haven't completely figured out all the details, but it does raise some interesting possibilities, right? What if, in addition to all the medical stuff we do, we could also incorporate some stress management into our treatment plans?
Yeah, I love that idea. Mindfulness exercises in the waiting room, anybody. But on a serious note, I think it really highlights the need to take a more holistic approach to managing this condition. Now, before we get too zen, let's talk about a concept that I know has been making waves in ophthalmology lately, pachychoroid.
Ah, pachychoroid. It's definitely been causing a stir. What's really interesting is that it might not just be some random finding. It could actually be a key piece of a much bigger puzzle. The pachychoroid disease hypothesis suggests that CSE isn't just this isolated condition, but it could be part of a whole spectrum of problems in the choroid and retina.
Okay, so break that down for me. Where does CSE fit into this whole pachychoroid story?
All right, well, imagine a timeline. On one end, you have uncomplicated pachychoroid, just a thick choroid hanging out, not causing any trouble. Then as time goes on, this thickening can start to lead to some subtle changes in the RPE, what we call pigment epitheliopathy. And then, boom, CSC enters the picture with that fluid buildup. And in some cases, things progress even further, and we see neovascularization, those abnormal blood vessels start to form.
Okay, wow, that's quite the journey. But here's what I find mind-blowing. You're saying we might be able to actually catch these pachychoroid changes even before patients have symptoms.
Exactly. Think about those hyperfluorescent zones we see on ICGA. They're like early warning signs, flashing red lights telling us, hey, something's brewing down here.
Yeah.
And if we can detect those changes early enough, think about the possibilities. We might be able to prevent CSC from developing altogether, or at least slow down its progression.
Talk about a game changer. Early detection is really key. But let's not forget about the patients who are already dealing with active CSE. To really figure out how to treat this, We need to dive into the pathophysiology, the why behind those fluid leaks and retinal changes.
Absolutely. It's like being a detective, looking for clues at the cellular level. And what we've found is that it all comes down to dysfunction in the choroid. We see leaky blood vessels, increased thickness, dilated veins. It's all happening back there.
It sounds like a recipe for trouble.
Yeah.
Are there any new theories emerging about how this all works?
One really intriguing development is Spade's venous overload theory. It basically proposes that the venous system in the choroid gets overloaded, leading to increased pressure and those fluid leaks. And what's really fascinating is that the patterns we see in the veins of CSC eyes look a lot like what we see in conditions like vortex vein occlusion and fistulas.
Wow, that's a surprising connection. So now that we've peeked under the hood and seen what's driving this fluid buildup, let's explore our toolkit for fixing it. What are our options for treating CSC these days?
Well, if we're talking tools, PDT is definitely the Swiss Army knife of CSC treatment. It's versatile, effective, and has a pretty good safety profile, especially when we use the half-dose protocol.
PDT always seems to take center stage when we're talking about CSC. But tell me, why is half-dose preferred over the full dose, especially in those chronic cases?
It's all about finding that sweet spot, balancing effectiveness with safety. Half-dose PDT has been shown to work just as well as the full dose at resolving subretinal fluid and improving vision. But here's the best part. It comes with a lower risk of those side effects, like those annoying vision disturbances and the photosensitivity that makes people hide from the sun for a few days.
And let's not forget the practical benefits for us as clinicians. It's easier on the budget, and it helps us conserve those verteporfin supplies. It's a win-win situation for everyone involved.
You got it. But before we go crowning PDT as the undisputed champion, let's remember we do have other tools in our arsenal. Laser photocoagulation can be a good option for extrafoveal leaks as long as we're careful to avoid the fovea.
Right, no laser on the fovea. That's a golden rule. And then there's HSML and TTT, although the evidence for those isn't quite as robust as it is for PDT.
True. It all comes down to weighing the risks and benefits for each individual patient. Taking into account things like the severity of their disease, their overall health, and even their own preferences.
Speaking of personalized care, those flowcharts in the guideline, Figure 7 and 8 are super helpful for figuring out which treatment path to take for both acute and chronic CSE.
They're like our GPS systems, guiding us through all those management options. But even with the best GPS, sometimes you need to adjust your route based on what you encounter along the way.
And that's where our clinical judgment comes into play, right? No algorithm can replace good old-fashioned medical expertise.
Couldn't agree more. And that's what makes this field so challenging and so rewarding. We have to be both scientists and artists using the evidence, but also tailoring our approach to each individual patient.
And of course, we can't forget one of the most important steps in any treatment plan, trying to eliminate or at least minimize corticosteroid use whenever possible.
It's like trying to put out a fire while someone keeps pouring gasoline on it. If we can address that modifiable risk factor, it can make a world of difference.
On that note, there's something that isn't explicitly mentioned in the guideline, but it's something I always find myself thinking about. How much does a patient's overall health and lifestyle play into their risk of developing CSC in the first place, and how well they respond to treatment? We know there are connections to stress certain medications, even pregnancy. Could there be other factors we haven't fully explored yet?
That's a great question. It's like the classic nature versus nurture debate, but in ophthalmology, we can't just focus on the anatomy and physiology of the eye. We have to think about the whole person, their habits, their medical history, their emotional well-being, the whole shebang.
They say the eyes are the window to the soul, and maybe to the rest of the body as well.
Maybe we should start asking our patients about their sleep habits or how stressed they are on a scale of 1 to 10.
I think you'd have patients lining up around the block to book appointments with you. But joking aside, I think you've hit on something really important. We need to broaden our view of CSC, look beyond just the eye itself, and consider all the factors that could be contributing to its development and influencing its course.
I totally agree. It's all about connecting the dots, seeing the bigger picture, and remembering that every patient is unique. What works for one person might not work for another, and we need to be flexible in our approach.
Well, we've laid a solid foundation for today's deep dive, but this is just the beginning. Stay tuned for part 2, where we'll break down those management flowcharts and dive into some of the trickier scenarios we face in clinical practice.
Looking forward to dissecting those flowcharts with you. And hey, if you're enjoying this deep dive so far, we'd love for you to follow the podcast and leave us a 5-star rating. Your support means a lot to us. So are you ready to tackle these management flowcharts?
Always up for a challenge. Okay, so let's start with acute CSE Figure 7 in the guideline gives us a really nice pathway. But before we even think about treatment, I think it's worth emphasizing how important that initial assessment is.
Absolutely. You can't treat what you don't understand, right?
Yeah.
A good history is crucial, especially when it comes to things like corticosteroid use. And then, of course, multimodal imaging is our best friend.
It's like our detective kit giving us all the clues.
Yeah.
So let's say we have a classic case of acute CSC, single focal leak, some minimal RPE changes. The patient's been having symptoms for less than 4 months. What's our first move?
You know, in that kind of situation, I usually take a watch and wait approach. Remember, acute CSC has a pretty good chance of resolving on its own, especially in those first few months. Sometimes the best medicine is just giving it time.
Patience is a virtue in ophthalmology.
Yeah.
But obviously, we're not just sending the patient home and forgetting about them. Close follow-up is key, right?
Oh, absolutely.
Yeah.
We need to keep an eye on things, make sure that fluid isn't acting up, and rule out any new problems. Repeat imaging is essential. We don't want any surprises.
Now, what about those patients who are really struggling with vision loss, or if their job depends on having really good eyesight? Waiting might not be an option for them.
Right. Sometimes we need to be a bit more proactive, and that's when we start thinking about treatment. Remember, our goals are to get that vision back as quickly as possible and to prevent those long-term complications like chronic CSC or, MNV.
Okay, so if we're going to intervene, what's our go-to move in these acute cases? Is it time for the PDT?
Whoa! Hold your horses there. PDT is a powerful tool, but it's not always the first line of defense, especially in acute CSC. We have to remember it does involve giving the patient verteporfin, and while the side effects are generally pretty mild with the half-dose protocol, we still want to use it judiciously.
That makes sense. So what are our other options? If the leak is extrafoveal, can we just zap it with laser?
Ah, good old laser. It can be a good option for extrafoveal leaks as long as they're far enough away from the macula, but we absolutely cannot use thermal laser on any leaks that are on the fovea. That's a big no-no. We could end up doing more harm than good.
All right, no laser on the fovea. That's ophthalmology 101. Okay, so let's switch gears and talk about chronic CSC. What makes it different from the acute form, and how does that change our approach to managing it?
Chronic CSC is like that stubborn stain that just won't go away no matter how much you scrub. It's basically defined by that subretinal fluid sticking around for more than 3 or 4 months, and we often see more significant changes in the RPE on imaging.
And the longer that fluid hangs out, the higher the risk of permanent vision problems, right?
You got it. That's why jumping in early is so important. With chronic CSC, our goals shift a bit. We're still aiming for complete fluid resolution and getting that vision back, but we're also really focused on preventing further damage and trying to avoid those long-term complications.
So in this chronic setting, does PDT finally get to take center stage?
It's PDT's time to shine. Remember those big clinical trials, PLACE and SPECTRA? They really showed us that half-dose PDT is the MVP for chronic CSC. It outperformed both HSML and eplerenone.
So we've got good evidence to support using PDT, but why half dose, especially when we're dealing with a more persistent problem?
Again, it's about finding that balance between efficacy and safety. Half-dose PDT delivers the results without so many side effects. Plus, it's easier on the budget, and it helps us conserve those verteporfin supplies. It's a win-win all around.
It really is. But even PDT isn't a magic bullet. There are going to be some patients who just aren't good candidates for it.
Absolutely. There are always exceptions. If a patient has another medical condition that makes PDT risky, or if they just can't handle the thought of getting an injection, then we have to consider other options.
So what are our backup plans if PDT is off the table? Do HSML or eplerenone step up to the plate?
They can be useful in certain situations, but let's be real, the evidence for those treatments just isn't as strong as it is for PDT. Those head-to-head trials showed us what really works best.
So PDT is our first choice, but we always have to think about what's best for each individual patient. Okay, let's talk about a complication that can really complicate things. Posterior cystoid retinal degeneration, or PCRD. What is this, and how does it change our management strategy?
PCRD is like the uninvited guest that shows up when chronic CSC has been hanging around for too long. It's a sign that those persistent fluid leaks have started to cause some real damage to the retinal structure. We see fluid building up inside the retina itself, not just underneath it. And it can really affect vision even in areas where that subretinal fluid has already resolved.
So it's a double whammy of fluid problems.
Yeah.
Does PDT come to the rescue here too?
Well, that's where things get a bit tricky. PDT can be helpful for some cases of PCRD, but it's not always a guaranteed win. Remember, PCRD is a more complicated issue. It's not just about stopping the leaks. It's about dealing with the damage that's already been done.
It's like trying to fix a leaky faucet after the whole kitchen is already flooded. You've got a much bigger problem on your hands.
Exactly. And that's why we have to be realistic about what we can achieve with PCRD. Even with treatment, some patients might have some lasting vision problems.
It's a good reminder that early detection and treatment are so important for minimizing those long-term complications. Okay, let's talk about another scenario that can be a real challenge. CSC complicated by MNV or macular neovascularization.
Oh, MNV. It's like the villain that sneaks in and causes all sorts of trouble.
It sounds pretty scary. How do we approach treatment when we have both CSC and MNV to deal with?
It's definitely a more complex situation. While PDT can be effective for MNV that's related to CSC, we often need to bring in some extra help. Anti-VEGF injections, those angiogenesis inhibitors might also be part of the plan, especially if those abnormal blood vessels are really taking off.
So it's a more multi-pronged approach, tackling the fluid leaks in those new blood vessels. But how do we even know if MNV is lurking in the background? It seems like it could be easy to miss.
That's true. MNV can be sneaky. That's why those advanced imaging techniques like OCT angiography are so crucial. They're like our X-ray vision, helping us spot those abnormal blood vessels even before they start causing noticeable symptoms.
It's like having a superpower. So let's say we've diagnosed CSC, we've considered all the different factors, and we've put together a personalized treatment plan for our patient. What happens next? Can we just sit back and relax?
Not a chance. Chronic conditions need constant attention. We need to stay on top of things, make sure the treatment is doing what it's supposed to, and watch out for any signs of the condition coming back or any new problems that might pop up.
It's more of an ongoing partnership, right? We're working together with our patients as a team to manage their condition and protect their vision.
I like that analogy. It's a team effort and communication is key. We need to make sure our patients understand what's going on with their condition, what the treatment plan involves, and why those follow-up appointments are so important.
Absolutely. We're not just treating eyes, we're treating people, and that human connection is so important. Before we move on to our final thoughts, I wanted to come back to something you mentioned earlier about the role of lifestyle factors in CSC. I'm really curious to hear more about what you think about this.
You know, it's an area that I think we need to pay more attention to. We know stress can trigger CSC, but what about other things like diet, exercise, sleep? Could they play a role in either preventing or worsening the condition? It's definitely an area that needs more research.
I'm so glad you brought that up. It's like we're expanding our understanding of CSC and thinking about the whole person, not just their eyes.
Exactly. And it goes back to that concept of personalized medicine. We need to consider each patient's individual circumstances and tailor our approach accordingly. Maybe for some patients, making some lifestyle changes, like finding ways to reduce stress or adjusting their diet, could be a helpful part of their overall management plan.
That's a great idea. It's about empowering patients to take charge of their health and well-being.
And it's about us as clinicians being open to exploring all the options. We shouldn't be afraid to think outside the box and consider factors that might not be in the textbooks or the guidelines.
This conversation has definitely given me a lot to think about.
Yeah.
It reminds me that we're always learning and there's always more to discover, even about conditions that we think we know well.
Absolutely. And that's what makes this field so exciting. There's always something new to learn, a new challenge to face.
So are you ready to move on to our final thoughts?
Let's do it. I'm excited to wrap things up and leave our listeners with something to ponder. All right, so, we've covered a lot of ground in this deep dive, but there's always more to learn. What are some of those unanswered questions that you think will drive the future of research in CSC?
Well, I think one of the biggest mysteries is why some people get CSC after just a tiny bit of exposure to corticosteroids, while others can use them for years with no problem at all.
You know what makes some people so susceptible? Is there some kind of genetic link that we haven't figured out yet?
Those are some great questions. And, what about those patients who just don't fit the mold? Their symptoms are all over the place, the imaging doesn't quite match up, and their response to treatment is unpredictable. It reminds us that we can't always rely on algorithms, and sometimes we just have to trust our gut. Definitely every patient is different, and we have to be ready to change our approach based on what they need. I think that's what makes medicine so interesting.
I agree. And speaking of interesting, let's go back to that connection between CSC and stress. If we accept that stress can actually play a role, what does that mean for our patients? Are we just telling them to relax, or is there something more we can do?
I think we need to stop thinking of stress as something that's all in their head and acknowledge that it can really affect their eye health. What if we started teaching our patients some stress reduction techniques? Some breathing exercises they could do or some mindfulness practices.
I love that. It's about empowering patients to take control of their condition and their overall well-being. It's a more holistic approach, recognizing that the eyes are part of a larger system.
Exactly. And it could even lead to New ways to prevent CSC. What if we could identify patients who are at higher risk, maybe based on their personality or their lifestyle, and then give them some tools to help reduce that risk?
That's a fantastic idea. It's like preventive ophthalmology, catching those problems before they even start.
It's like fixing those little cracks in the foundation before the whole house falls apart. Early intervention is key.
You're absolutely right. And let's not forget about early detection. We talked about those signs of pachychoroid on imaging. What if we started screening patients who are at high risk even if they don't have symptoms yet?
It's like being proactive rather than reactive. Catching things early can make a huge difference in the long run.
I couldn't agree more. This is where we have a real opportunity to make a difference. And it all starts with awareness for both doctors and patients. We need to stay up to date on research, be open to new ideas, and be willing to think outside the box.
I think this deep dive has given our listeners a lot to think about and hopefully spark some new questions.
I hope so too. And if you want to dive deeper into this topic, we've got a link to the full journal article in the episode description.
And as always, we'd love to hear your thoughts and questions. Let's keep this conversation going.
We're all in this together, trying to provide the best care for our patients.
And if you enjoyed this episode and learned a thing or two, don't forget to leave us a 5-star rating and tell your colleagues about the deep dive.
We appreciate your support.
Until next time, keep those minds sharp and those retinas healthy.